actually causing the compression of the small blood vessel and causing good hemostasis. And then after some time, there is a hypoxia gradient. When this thing happen, the cell will secrete this VGF, the vein growth factor, is basically to promote the sprouting of the blood vessel. This lead to increase in angiogenesis. So secondarily, it modulates the inflammation by increasing the cellular response, migration, division, and differentiation. This is a fibroblast where when it is, after putting a negative pressure wound therapy, microscopically can actually thicken the cell body and increase ATP, increase in cytochrome oxidase, and increase the cell growth factor. Other than that, it's actually increase the neurogenesis by secretion of the NGF, the neural growth factor that leads to neurogenesis. So this is the normal process of wound healing, but with the usage of this negative pressure wound therapy, it will first enhance the hemostasis, and then will promote inflammation and sucking all the leukocyte out, increase the formation of granulation tissue by increased angiogenesis. Then lastly, remodeling by increasing formation of collagen protein later will help the wound healing. So commonly, negative pressure wound therapy is more popular in this area where they used to treat the chronic wounds such as the sacral sore, this abdominal area, the lower limb diabetic ulcer, and leg ulcer, vasculitis. But why is it not so popular in oral maxillofacial surgery? One thing is because of the contour of the head and neck, because it's quite difficult to get a airtight seal because of our hair, body hair, beard, mustache. Difficult. We actually difficult to stick this semi-permeable dressing, but actually we can overcome that with a bit of tips. Other than that, healing tissue can grow into reticulate form and make it a removal difficult. It is expensive. That's the most important one, because we need to actually call a supplier and then bring the machine and buy the sponge. It involves money, so that's why it's not very popular in hospital. And other than that, commercial negative pressure wound therapy not readily available in some center. Like last time I worked in Temerloh, I don't think this commercial negative pressure wound therapy is available in Temerloh. Or let's say we want to use it, we need to call the supplier and arrange them. They need to come in and provide us and loan us the machine. And the lastly is because doctor not aware of this technique. So a bit of application in oral maxillofacial surgery. Xia et al. Actually has used it in the upper third maxillofacial reconstruction, where they use this negative pressure wound therapy in a trauma patient who lost this with a skin loss and exposed bone. So basically how they do it, they actually decorticate the superficial cortical surface of the frontal bone, and then do a bit of debridement around the wound and place the negative pressure wound therapy. And after 6 weeks, you can see a good formation of granulation tissue there. And then Xia et al. Actually did this local flap to close the wound. Very good outcome. What about the middle third maxillofacial reconstruction? Andrew et al. Has used this to treat this necrotizing fasciitis involving the orbit and the face area, where initially he need to do an aggressive debridement and then placement of the negative pressure wound therapy. As you can see, as early as 4 weeks, you can see a good formation of granulation tissue, and after 6 weeks, more healthy tissue bed. And later he actually reconned this only with the prosthesis. And then negative pressure wound therapy also can be used in the treatment of the severe deep facial space infection. Chow J et al. Actually used this to treat deep facial space infection secondary to odontogenic infection, where he used this rubber drain inside. Together with that, he packed this foam inside, and then closed with semi-permeable dressing on top of it. He placed the negative pressure wound therapy. You can see how actually it suck up all the pus. Quite big amount of pus has been sucked up, and he actually managed to get a good wound healing after 2 weeks. Other than that, this negative pressure wound therapy is very useful. Zhang et al. Basically used this to treat osteoradionecrosis, where in his patient, he after post-tumor ablation, he reconstruct with 2 free flap with radio forearm free flap and this pec major flap, where radio forearm free flap and fibula myocutaneous flap, where got after the radiation, he actually found out that patient having this osteoradionecrosis with exposed bone, exposed plate, recon plate here. So actually what he did, he basically explore it, remove the plate, do a bit of wound debridement, and then pack the foam and put negative pressure as early as 2 days post-op. The infection settle, and as you can see, good formation of granulation tissue there. Other than that, this negative pressure wound therapy also can use as a booster, where in this paper, Andrew et al. Has used it on top of this SSG, split thickness skin graft, post reconstruction, where after he placed this SSG, he placed this foam and negative pressure to increase the take up of the SSG to the wound bed. So actually, what are the difference between commercial and our in-house cost-effective and accessible negative pressure wound therapy? So how we do it? Basically, we do the same thing. The most important thing is the aggressive wound debridement. After aggressive wound debridement, we apply this negative pressure wound therapy with intermittent suction for 1 hour, then 15-minute rest using wall suction at 125 millimeter mercury. And then we change the dressing every 3 days until we feel that patient develop a healthy wound bed lah. So during the change of the dressing, we can do a local debridement also, and then to make sure it is free from any necrotic tissue before actually we reconstruct the defect. At the same time, you have to remember that we need to optimize the patient with this systemic antibiotic. We need to control the blood sugar if patient is diabetic, and hydrate the patient well, and provide a good nutritional support, as the nutrition helps in wound healing. So these are our DIY kit, so-called DIY kit, where actually we use a NG tube here, rice tube, yeah, with this semi-permeable transparent dressing. We prepare like small dressing and big size dressing and paraffin gauze, and also we just need a wall suction to be set at 125 millimeter mercury. And this PU sponge is actually our secret sponge, where actually this PU polyethylene sponge actually you can buy at nearby grocery store. There's 2 types. One is like only foam, another one got another rough sponge on top of it, but you choose this one without the green rough surface one. You just choose this plain sponge. It's advisable for you to get other than red color sponge, because if let's say the sponge got dirty, you actually can see. But if let's say it's red, you actually cannot really appreciate if let's say it is soaked with blood or any discharge. Okay, so I will share you a bit of case series, case that we use our DIY negative pressure wound therapy. Actually, this case is all in hospital Temerloh. The first case, a 58 years old Malay female. Actually, she's having this uncontrolled diabetic with a 12.8 millimole reading. And then the source of infection is actually carbuncle and site at the preauricular region, where we apply this negative pressure wound therapy for 9 days. So as you can see, we did an aggressive wound debridement to clear off all the necrotic tissue, leaving behind all bleeding area. And then as a tip, you need to put a paraffin gauze at the base. Why? Because if let's say you don't put this, you straight away put the sponge at the base. Later, when you want to remove it, it's quite painful for the patient because it's attached to the base, and also it can bleed. But with this paraffin gauze at the base, it's actually creating like a barrier where you can remove this sponge easily later. And then you take the sponge and then you cut it to the shape that you want based on the wound size. You poke it with this straight artery for the passage of the NG tube, and then you put this NG tube all the way in. After that, you need to seal this periphery first. This is the periphery first. After you seal the periphery first, then only you seal everything, complete seal everything. And this is how it looks when, if let's say it is no leakage, it's actually good, confirmed good seal, where you can see actually the sponge shrink and all the blood, everything will be sucked up. Okay. Right. That's how it works. Right. So in this patient, after completed this negative pressure wound therapy for this patient, I think for how many days? Just now, for 9 days. This one for 9 days. So we changed it 3 times, and after that, as you can see here, very good granulation tissue has been formed at the bed. Yeah, this is good for, I mean, it's ready for reconstruction, where I did this bi-rotational flat closure here. And this is the result post-op 3 months, where as you can see, very minimal scar and patient has no issue with the facial weakness or anything. Okay, then I go for the case number 2, where this 42 years old Malay female, Malay female with this hypertension, diabetes, and complicated with CKD. Her source of infection is actually from the infected pimple at the right side of the cheek. And we did this negative pressure wound therapy for 13 days. So again, aggressive wound debridement, placement of negative pressure wound therapy, and as early as day 7, you can see a good wound bed with the granulation tissue. Then we put patient under GA to do SSG, and this is how it looks like post-op 4 months. Case 3 is a bit longer because it's quite big compared to other cases. This 47 years old Malay male having this uncontrolled diabetic. And then the source of infection is actually from the odontogenic, from the tooth. The site involved is actually at the right infraorbital, extended to right to the buccal and the zygoma region. And we put this negative pressure wound therapy for 16 days. This is how it looks like when he first presented in emergency department. So what we did, after few days we did IND, the area become necrotic. So we put him under GA to do aggressive wound debridement, place the negative pressure wound therapy, and complete seal of the area. And this how it looks like 7 days post debridement. 16 days post debridement, I found out that the wound is too big. Then I do a bit of closure here below the infraorbital area to make the wound smaller a bit, and then put patient under GA for SSG. And this is how it he looks like after 6 months. Good. I mean, the SSG has taken up nicely. So this is comparison pre-op and post-op, how different he is. And this is the last case where the 62 years old Malay male, also with uncontrolled diabetes. The source of infection is from carbuncle at the right infraorbital region. In his case, he's the fastest that we did. Only need 7 days of negative pressure wound therapy. We placed we did aggressive debridement and placement of the negative pressure wound therapy. This what it looks like 7 days post debridement, and then I just need to do a small advancement flap for closure of this wound. This is how he's looked like before and post op 1 month. As you can see, the acceptable scar at the infraorbital region. So in terms of costing, how different it from our negative pressure, our DIY negative pressure wound therapy with commercial negative pressure wound therapy. As you can see, the case number 1, we changed the negative pressure for 3 times. It only costs about 100 ringgit and 50 cents. While if let's say we simulate the cost by using a negative pressure wound, commercial negative pressure wound therapy, it will cost 1,325 ringgit, which is I think about 11-12 times higher. And then case number 2, we changed for 4 times. Our negative pressure wound therapy only costs about 168 ringgit, while commercial one costs 1,433 ringgit. Case 3 is the longest, where we changed like 6 times. Only cost us 411 ringgit, while commercial negative pressure wound therapy will cost up to 1,675 ringgit. In case 4, the shortest one, where we only change the negative pressure for only twice, it only costs us 67 ringgit, while commercial one will cost about 1,293 ringgit. These significant differences definitely will benefit the patient. So what are the advantages of our DIY negative pressure wound therapy? It promotes faster wound healing, and it avoids long periods of painful dressing changes and irrigation. How actually we manage this actually complex wound? Are we still doing this soap gauze packing or povidone gauze packing that patient need to stay in the ward for a month? So basically, this really helps in the wound healing and really shorten the hospital stay of patient and reduces a lot of hospital costs, and indirectly also reduces patient patient need to pay, prevent that patient need to pay high cost to the hospital. So apart from that, the negative pressure wound therapy also has a few contraindication that you cannot place the negative pressure wound therapy in the presence of malignancy of the wound, and then untreated osteomyelitis, unexplored fistula, necrotic tissue with eschar present. Eschar is actually dead tissue fall off from the skin. You need to remove it before you put this negative pressure wound therapy. Exposed vasculature, yeah, you don't want it your vascular to bleed, and exposed nerve, exposed anastomosis site of blood vessel. So you need to avoid all this. So what a take-home message? First, aggressive wound debridement is crucial before placement of negative pressure wound therapy. You need to clear off the infected wound, all the necrotic tissue surrounding and at the bed. You have to really do aggressive wound debridement. You cannot like just do a little bit, cannot. Then at the same time, simultaneously, you should optimize patient systemically. You have to give patient with a good IV antibiotic, good control of your patient. If patient having diabetes, good nutritional support, as patient will heal faster with a good nutritional support, and have to maintain vacuum seal all the wound all the time. So at the same time, you also need to discuss the treatment option after negative pressure wound therapy, as facial defect will have major impact in the psychological to the patient, as patient feel that he actually the face is damaged after the debridement, the aggressive debridement. So as a conclusion, negative pressure wound therapy is a good adjunct to replace conventional regular dressing. Our in-house negative pressure is low cost and effective in managing complex wound and maxillofacial region. Due to material easily available, our in-house negative pressure wound therapy can be used in any oral maxillofacial center. You can find all the material that we use actually in hospital. So basically you can do it yourself. No need to ask for commercial to come and provide you with all the materials. I would like to acknowledge a few people in Hospital Temelloh, my previous HOD, Dr. Karuzaman, all my officer, for helping me together managing all the cases that I have presented just now. These are list of my references. With that, thank you. Any question, you can always email me at my email, drshahir@gmail.com.
Thank you very much, Dr. Shahir, for the great sharing. Now we are open for the question and answer session. So please don't hesitate. If you do have any burning question that you want to ask Dr. Shahir, please ask now. Or if you are shy, you can still email him at his email, just show. But I do have one question for you.
Yeah, sure, Stella.
Is there any difference if we use different kinds of the sponge? For example, like different density. For example, the sponge that you use for the shower or the sponge that you use to wash the dish is slightly different in density. Would it make any difference?
Okay, the one that you use for shower, it has a lot of like hole, right? Inside is bigger hole compared to the one that we use to wash dish, kan?
Yes.
So it's preferably you use the one with the to wash dishes one, not like use for shower one, because shower one is not dense. I mean, it's got a lot of hole inside, right? For the shower one. So it's preferably to use the one that we use to wash the dishes, because it's more compact inside, you know. And then the idea is, let's say it is compact, so you can get a good seal compared to, let's say you use the shower one, got a lot of hole there, it's a bit difficult for you to get the seal.
So that means that the sponge to wash for the car wash will be better because the density will be the higher than the dishwasher sponge, right?
But the car wash one is a big sponge, and then if you want to cut, it's a bit difficult.
Yes.
So I would suggest use the dishes one, because the dishes one, what to wash the dishes one is like one palm size like that.
So there's one question from Dr. Jeremy. How often do you change the negative pressure wound therapy dressing? And also, does the patient need to stay in the ward for the entire duration of the therapy? I think Dr. Jeremy has missed the earlier session.
Yeah, basically, I use the patient definitely have to stay in the ward for the negative pressure wound therapy for my protocol, I usually change it day 3. Why day 3? Because normally day 3, the sponge is already soaked. And then when you remove the sponge, actually you can do a bit of debridement to make sure to fasten the healing, where you can see a bit of necrotic tissue here and there. Actually, you can debride a bit. Then only you apply back a new negative pressure wound new sponge, and put negative pressure wound therapy. Usually, our patient will stay for at least need to wait in the ward. The longest also about 2 weeks plus before patient is ready for reconstruction. After we complete the reconstruction, then only we allow patient to go back home, because you can't be leaving patient with a big wound like that. So and then patient normally cannot keep it clean in the ward, so in the at home. So basically we keep the patient for IV antibiotic, and easy for us to take care of the wound.
Okay, the second question from Dr. Jin: is it possible to replace the sponge with things like gumji?
Gumji is not suitable because it's absorbed. PU is actually PU is actually absorbing, but when you squeeze it, is easily recoil back to the original position, original shape. So we don't advise using gumji.
Okay, Dr. Katie, thanks for the wonderful presentation. I have a few questions. Would a combination of the hyperbaric oxygen work better in combination with this technique?
Hyperbaric oxygen therapy. Hyperbaric oxygen therapy actually do help in wound healing because it's also promoting the angiogenesis. But I think because of patient require this debridement, and then IV antibiotic is good. I mean, the negative pressure wound therapy is good enough, because as you can see, my 4th patient, actually we just need 1 week. So if let's say you want to put patient under this hyperbaric oxygen, is a bit it's not convenient because in Malaysia also not every center have this hyperbaric oxygen. So if you can manage it within one week, then why you want to send to hyperbaric oxygen? It's not really I mean convenient for the patient lah, in my opinion.
Okay. The second question from RT is: would it be advantageous to have 2 rice tubes instead of 1? With 2 rice tubes, we can irrigate the wound with saline, dermacine, 1 input and 1 output.
Oh, so advanced. Actually, it works one way. Why you need negative pressure? Because you actually want to promote the angiogenesis and suck up all the exudate to reduce the bacterial load. Let's say one irrigate, 1 goes out. I think it doesn't serve a purpose of negative pressure. Another one is the idea of doing negative pressure is you want to avoid multiple changing of the the dressing. I only change it for every 3 days, so it's really comfortable for the patient. If let's say you just simply irrigate, like I said, day 3 when you remove, you can clean, debride easier compared to you just put 1 irrigation, 1 tube in and 1 tube out. So I don't think that is serve the purpose of negative pressure wound therapy.
The third question from Katie: is it possible that the skin will form over the defect without the need for the split skin graft if we use this technique for a longer period of time?
No, if let's say you have big wound, you still need to cover it because yes, it causes a macro deformation where the wound edges will come together. But the idea of putting the skin graft SSG is to make sure it can heal with the skin tissue. If let's say you leave it for a longer time, it's just forming like a granulation tissue like that without your epidermis and dermis there. So after you put negative pressure wound therapy, if the wound is quite big, you cannot close with local flap, you have to do with the SSG.
Okay, another question from Dr. KA, OMFS Melaka. Thank you, Dr. Shahir, for your presentation. Can I ask about the pressure applied? Can you repeat back the common pressure that you use? Is there any benefit or risk if we increase or a light higher than the normal pressure?
Okay, 125 millimeter mercury is as suggested by this Argenta and Moriquas, where they did the first animal study on it. They found that the ideal pressure is 125 millimeter mercury. If let's say you go higher than that, one thing you can easily clog the tube. One thing you clog the NG tube, and then if too high pressure, instead of you promoting all the good thing, angiogenesis on all that, you create like a trauma to the tissue because you suck quite high. If let's say common sense, if let's say you suck your skin, it will causing like ecchymosis on your skin like that. So 125 millimeter mercury is a good the ideal pressure that's suggested by the literature. And commercial negative pressure wound therapy also use this 125 millimeter mercury pressure.
I think your answer have answered to the next question. What will happen if it decrease or increase the pressure? Maybe we go to the next by Dr. Krishna Razak. Thank you here for an interesting presentation. In your protocol for the negative pressure wound therapy as blister dressing for the SSG, is the pressure similar to your negative pressure wound therapy for the wound infection?
Yes, it's similar, 125 millimeter mercury. That what they practice, I think by Andrew just now, Andrew et al., where he used this negative pressure wound therapy as a booster.
Okay. Another question from Dr. Siti Nur Nabiha. Congratulations on your beautiful presentation, Dr. Shahir. My question is, how did you apply this negative pressure, negative wound pressure therapy at the preorbital region, especially in the case number 3 and number 4?
Okay, good question from Dr. Siti Nur Nabiha. A bit of tips from me. For the orbital region, you actually can use this iPad to close the eye to get a good seal around the eye. So if you don't put that iPad on the eye, it's quite difficult for you to get the airtight seal there. So my tips is to cover the eye, and then cover the eye with the iPad or gauze, and then you can put that small semi-permeable dressing first at the periphery, and then only use the big one to cover and get the airtight seal.
Okay, from Dr. Hasmil. Salam, Dr. Shahir. Thank you for the eye-opening presentation. Since your makeshift negative pressure wound therapy is not portable, so the patient need to be admitted during the whole duration of the therapy, would you consider using the portable electronic A-palm as your future innovation?
Actually, that is in my plan lah, where I want to invent a new, a portable suction for this negative pressure wound therapy. Yeah, a bit of disadvantage where actually in our protocol we do intermittent negative pressure wound therapy, where you continuous suction for 1 hour, then 15-minute rest, and then continue 1 hour and 15-minute rest. The idea is for patient, at least during the resting time, patient can actually go to the toilet or move around. And then actually when you put the negative pressure wound therapy for let's say about 5 to 10 minutes, patient will feel a bit pressure and a slight pain there. Then after some time, patient will get used to it. So the idea of we do this intermittent negative pressure is for patient to have a resting time, and then patient can go to the toilet and more comfortable. So it's good to have something portable actually, where a device where it can last long. Like commercial devices can last up to 20 hours continuous run. So I think that is something that I will look into in my next project of this innovation. Yeah, that is one of my plan.
The next question is related to this. How do you make sure that the pressure is maintained where you have the intermittent rest for 15 minutes?
How I maintain?
Yeah, the pressure at 125. Yeah, after you have 1 hour, then you stop for 15 minutes, then you start again another hour, right? So how do you maintain the pressure?
I maintain the pressure by controlling the wall suction. Wall suction got like a knob there you can control, right? 125 millimeter mercury. So you just need to adjust it to 125 millimeter mercury, and you have to make sure your sponge is actually being you notice just now I show my video where when it is vacuum, the sponge will squeeze like that, right? So if it vacuum, it will squeeze. So you have to make sure all the periphery have a good seal, so it is vacuum. The idea is to make it vacuum, and then the suction you need to control it by the knob. You can actually adjust at the wall suction.
Okay, the last question by Ant is, hi Dr. Shahir, how do you ambulate the patients while maintaining the pressure?
Okay, let's say patient in the ward, and then we want to call the patient to the ward, and then patient actually can have that 15-minute rest. We can call patient after patient complete 1 hour, that 15-minute rest, we can push patient to clinic, and in the clinic we still have the wall suction, then we can continue using that to maintain the negative pressure at 125 millimeter mercury.
I do have one question from me.
Okay.
How do you improve the sterility of the sponge? Have you considered to send it for sterilization? Like
yeah, just now I showed in the slide where actually you buy from grocery. After that, you just need to put it in the autoclave. I mean, to pack it inside the autoclavable paper, and then seal it and autoclave it in the autoclave. Sterilize it in autoclave. Then only you can use in the patient.
Mm-hmm. Is there any other question from the participants? Okay, this is from Prof. Dr. Katrina.
Okay.
How soon do you start the negative pressure wound therapy in the infection cases? Immediately after IND?
Okay, good question. Usually when patient presented to you, maybe with it is in a cellulitis stage where the abscess haven't formed yet. So usually we wait for a while for antibiotic to work, and after some time the abscess has been formed, then I will do IND to release the pressure. Then after that, then only you plan for, because you need some time also to plan for put patient under GA for debridement or saucerization. So after you release the pressure IND, then you plan straight away for saucerization or debridement. Then after the debridement in OT, you can straight away put the negative pressure wound therapy.
Another question from Dr. Fadli. Thank you for such a wonderful talk. How do you achieve the complete seal of the wound at the hair-bearing area, for example, like the scalp? Do you shave your patient's hair?
Yeah. Another tips from me, if patient got beard or mustache or hair, you can ask the patient to shave first. And then that's why we change every 3 days, where after few days, the hair will grow. And when you remove, you can shave again the area. And then to make sure a good seal, normally what I did, I will clean the skin with the alcohol wipe, the alcohol swab there, clean the periphery from oil, from dirt, from anything. So your semi-permeable dressing will stick nicely there. Because if let's say you got hair, got oil, your dressing won't stick nicely there. And then after 1 or 2 days, it will leak, and then you don't have the negative pressure anymore.
Okay, is there any more question from the participant? Feel free to type in the chat box.
Oh, so many questions, Stella.
Yeah, this is from Dr. Farah. Hi, Shahir, well done on your presentation. How do you maintain the pressure of the pressure wound while transferring the patient from OT table to recovery before arriving to the ward?
From OT table to recovery? Okay, like at recovery bay also you have wall suction, right? So try to utilize the suction, your wall suction, because like I said, we are cost effective and accessible. So try to utilize the wall suction, because I think in recovery also they have wall suction for suctioning, right? So after you debride, you put straight away negative pressure, and then while patient wake up, there's no negative pressure lah. So basically that one is something that you can like for a while, it's okay. For a while it's okay. Then after that, patient transfer to recovery area where you still got wall suction. You can directly attach the wall suction to the NG tube to get the negative wound pressure lah. So when patient transferred from recovery to normal ward, yes, there's no any suction. Then for a while it's okay. Then after patient arrive at in the ward, then straight away you put the negative pressure, for the wall suction to create the negative pressure. So yeah, it's got in between there, got no negative pressure, but it's something that is not crucial lah. So as long as you straight away after patient arrive to the ward, straight away attach back to the wall suction for the negative pressure.
Okay, is there any more question for our speaker of the day? Okay, if you do have any more questions, feel free to email Dr. Shahil. He is more than willing to answer you and to help you for this innovation in your hospital. Okay, so
yeah, I hope you all can start practicing this, because you can see a very good result. Within 1 week, you can see a good granulation tissue at the back. So you need to try. I already share my protocol that you can use. If you have any question, you can always email me.
don't forget to fill out the feedback form before you end the session. So now we have come to the end of the seminar. On behalf of the Oral Maxillofacial Surgery University Malaya, I would like to say thank you to Dr. Shahil for his generosity to share his experience in this new treatment for our oral and maxillofacial region. And also to all the attendants, to all of the participants, thank you for your active participation for tonight's seminar. So a very good night.
Thank you, everyone.
Thank you.
Stella, this presentation ada recording.
Just now Wei Jing record late.